Thank you very much for the kind introduction and moreover for the kind invitation to this excellent meeting. So we, long time ago, we published our early experience with endovascular repair of mycotic aneurysms. And despite the fact that it was a small number of patients, only 19, what we could find is that there was 11% 30 days mortality, but the survival was around more than 70% at 2 months. So this, obviously, like with all endovascular approaches, there was a higher interest in using that for mycotic aneurysms. And this is a recent publication from the Danish nationwide study, which actually showed that there is an increasing use of endovascular repair for emergent presentation of aortic infection with a decline of the open aortic repair. What they showed as well is that the survival rate is not that bad. So it's almost 50% of patients are alive at 10 years if it's done in the right multidisciplinary way without really big emphasis on whatever you use, whether endovascular repair, prosthetic graft, or sort of bovine patch tubes. This is another paper which looked at 23 patients. I'm just using it, which was published recently, because it just highlights the important point that we have to keep in mind. So if you had endovascular, if you had presented with mycotic aneurysm and you had conservative treatment only, you're very likely to be dead within 1 month. If you're fit enough to have an open repair, you're very likely to stay alive at least at 1 year. And if you have an endovascular repair only without conversion to open, again at 2 years, you're very likely to be dead. But what was interesting is that if you had an initial bridging endovascular repair and you were fit enough to have explant followed by reconstruction, the survival rate is around 36% at even 5 years. In my mind, just to go to cases, there are two main indications for endovascular repair. The first one is the bridging strategy, and the other one is compassionate. So when we talk about the bridging strategy, this is another one of the patients to highlight this approach, who was very young patient, 53, presented with, as you would expect, dizziness, feeling unwell, feverish, tired for a few weeks. And this is the CT scan, and this will show you that most of the aorta is fine, but you can see the blowout on the posterolateral aspect of the aorta, which is to some extent sort of being sealed by the anterior spinal ligament. So the plan for those ones was to stabilize them, bridge them with an endovascular repair, and then pass them on to my colleague on the stage here to take them out and reconstruct them. And what you have to see here is that there are certain factor that we have to keep in mind. So when we stent them, if we have enough space, we don't go all the way above to the renal arteries to allow for a space for infrarenal clamping. We don't extend the stent into the iliac system as well. We just need to achieve sealing because we can pull them out at the time of the reconstruction. And we try to steer away from any device with suprarenal fixation. So this is the CT scan post-reconstruction. What happened is this patient had infective discitis and required spinal fixation as well, in addition to the graft explant with reconstruction with deep veins. Another example, 77, very fit gentleman, just presented with severe back pain and collapse. What's noticeable is that he just had urinary tract infection treatment 4 weeks ago. And essentially, this probably was the source of infection. You can see the aorta is just falling apart at or just above the level of the renal arteries. Again, lucky enough that this is a posterior leak which is protected or sealed by the anterior spinal ligaments. If you go back again, you'll see that the aorta just below the renal is fine, and it's area around the visceral segment which is falling apart. So the plan here was just to stabilize them, bridge them. And to do that, we elected to go for chimneys for the SMA and the left renal artery, and snorkel for the right renal artery, and using a thoracic stent graft. And you can see the blowout here. And we used like a 1P thoracic stent graft, as you can see here. And this is the CT scan for this patient with the 2 chimneys and the 1 snorkel to the right renal. This is just while we buy time to give him the antibiotics and optimize him medically. Then he underwent a proper reconstruction, again by my colleague just next to me, Mr. Salam, where essentially all the stent grafts have been taken out, and this has been replaced with a bovine tube, if I'm correct. And he continues to do well so far. Last one for the bridging patient. This is a lady who presented with this mycotic aneurysm, which you can see sort of infiltrating or in contact with the loop of valve, probably the duodenum. So at this stage, what we wanted is just to stabilize her, and we elected to do that with a stent, even compromising the celiac artery, which already diseased at the origin, and we protected the SMA while we deployed the stent to make sure that there's no inadvertent coverage of the SMA. And this is how it looked like post-stenting, and then she went on to have explant of her infected graft. Now, the second indication in my mind is the compassionate treatment. And for example, this is a very sort of sad story of a 34-year-old gentleman who presented with massive GI bleed, arrested twice in the referring hospital. At some stage, he was not even fit enough to be transferred to us. 10 years ago, he underwent quite an extensive radical resection of esophageal cancer with reconstruction of the visceral segment of the aorta with bifurcated grafts, one branch going to the hepatic artery, another branch going to the SMA. The problem with him is that he was not fit enough for transfer, spent 2 days to try to make him fit enough, came to us, and this is how it looked like. You can see a mycotic aneurysm from the origin or the anastomosis of the bifurcated graft. What we wanted is just to stabilize him. So at this stage, we wanted a chimney to the main trunk of the graft from this aorta, as well as a TEVAR, which sealed him. Unfortunately, he was never fit enough to go the next stage, and talking to the general surgeon, they felt that they cannot offer him any proper reconstruction. The last case is for this 84-year-old gentleman admitted to ITU with sepsis. During the workup, they got him a CT scan, and on the CT scan, you will find quite sort of suspicious haziness in the lower part of the aorta, but no actual sort of mycotic aneurysm. This was discussed with us at one stage, and you can see also some haziness around the right iliac system. So we said, we just sit tight on him, repeat the CT scan in 48 hours. This is the repeat CT scan 48 hours later, and you can see that this haziness in the distal aorta has turned into a proper falling apart of the distal aorta. You can also see that the haziness around the right external iliac system has become more clearer mycotic aneurysm. And one of the challenges was that the extensive calcification of his access vessels. So we did a cut down on the right groin. You can see this is the initial run, and what I wanted to do is just to seal this external iliac aneurysm to start with, so we don't get in trouble when we introduce the rest of the devices. And then we sealed the aneurysm as we were planning. Again, he was never fit enough to undergo any proper treatment later on and passed away. So in conclusion, I think EVAR and TEVAR, they are still increasingly being used as urgent or emergent treatment for presentations of aortic infection. They should play one of two roles, either bridging procedure until we give them enough antibiotics for sterilization and optimize them, or just for compassionate reason. Thank you very much for your attention.